So good morning, everyone, or good afternoon. Thank you for joining the seminar today. It's a big pleasure for me to host Fernando with us today. So Fernando got the chemistry degree in 2000 at the University Complutense of Madrid. Then he did the PhD in bioorganic chemistry at UNED in 2006. Then he moved to Imperial College to the postdoc with Ramon Villar. And then he came back to Spain to Hospital Gregorio Marañón. And then he joined CENIC when I joined his group to the PhD some years ago. So back from then at CENIC, Fernando established the radiochemistry facility there. So he has been working, mixing nanomedicines with radiochemistry, as we are going to see today. Fernando joined the Institute of Química Médica in 2018, and then got the tenure position 1 year after. And he has been acting as deputy director of the Institute of Química Médica since then. His lab work, as you can imagine, in diagnostic tools, mixing nanomedicines with radiochemistry. And they are also doing some stuff with nanoparticles, with biofilms for bacterial infection, and also some 3D printing models. So yeah, thank you very much for coming today, and the floor is yours.
Thank you, all of you, for the invitation. Appreciate to be here, and appreciate to see all friends like Juan, that you have a nice incorporation to the institute with him. And well, I just wanted to show you today a little bit of what we like to do. I choose this title, but you will see that there are more things that can say that in terms of application. The core of the talk is the combination of nanomedicines and radioisotopes, basically, and what you can do with that. We like to work with this. We like to work with nanomaterials for molecular imaging, but we question ourselves sometimes, and we've been questioned if there is room for nanomedicines in imaging. Where are nanomedicines successful? If you look to examples that all of you surely knows, Doxil, one of the first nanomedicines approved, mRNA vaccines for COVID-19, or Onpatro for interference RNA, all of them lipid particles, not only lipid particles, Hensify, that are half-neon oxide particles that have been approved by the FDA as sensitizers for external radiation. So not only organic particles are successful in the clinic, all of them are cases where they are being used in the clinic. And I think what makes the difference is, in all these cases, the nano aspect of the nanomedicine makes the difference. They answer something you cannot do otherwise. And this may raise the question of something we've been working many years, that is the role of iron oxide nanoparticles in MRI. As you know, they were approved for many years, but then they were discontinued, basically because there was not clinical interest. We can discuss a lot if this is based on scientific evidence or in commercial interest, as we were talking before. But the reality is that nanoparticles, iron oxide nanoparticles for MRI has not made it yet. Maybe this is good news, because we have to continue looking for real clinical applications that make the difference, that you can do something you cannot do otherwise. And we think we can do that with this combination. We think that the combination of nanomaterials and radioisotopes makes sense. That is a, let's say, synergistic approach where both fields can benefit of the combination. So what I'm going to try to answer in this presentation are these questions. What can nanomaterials do for nuclear imaging or therapy? That would be the last part of the talk. how can radioisotopes benefit nanomaterials? So it's a two-way benefit. And what applications are made possible only by the combination? What can we do that we cannot do with the current tools? I hope I will be able to convince you that it makes sense. For us, all started with this, that in fact is part of Juan's PhD. We developed a few years ago these nanotracers. In fact, I like to call them nano radiomaterials rather than radio nanomaterials, because they are not nanomaterials preformed that then you radiolabel. They are radiomaterials that are synthesized in the nanoscale. In one step, we mix gallium-68 from a gallium generator, iron chloride as the iron source, and a co-18 that it can be dextrane and lately mainly citric acid molecules. We did it in the beginning in a microwave oven. You can do it also by regular heating. And in one step, you incorporate the gallium-68 in the core of the nanomaterials, and you have a very thick, in fact, this picture is wrong because the organic layer is thicker than the core of the nanoparticle itself. But we got what we wanted, that is positive contrast in MRI because of the small size of the nanoparticle, and simultaneously PET signal because of the gallium-68. Once we obtained this, we applied to everything we could from, of course, many mice, but also rabbits and pigs, mainly because of our interest in cardiovascular diseases, and rabbits and pigs are the best models for atherosclerosis, and we have used it for many different diagnosis tools. From tumor, that this was the first image we got with these nanoparticles, angiography by MRI, inflammation by PET. I will talk about these results now. Atherosclerosis in many different ways, from fluorescent, PET, thrombosis derived from atherosclerosis, or microcalcifications in the context of atherosclerosis, because this has been our main interest for the last few years. So in terms of using the nanomaterials for PET, for MRI, or for PET and MRI, we have done several things in the last years. And today I wanted to show you this. That is a study we published a few years ago, and two studies that we are about to send for publication. I have chosen this because I think they represent what I'm trying to sell in you today, that it makes sense to combine nanomaterials and radioisotopes, and probably the possible clinical application is more clear than in what we have worked a lot also, that is the MRI using iron oxide nanomaterials. So in this case, neutrophil in vivo detection, probably you know the story because Juan was the starring in this story. So we came to know this peptide. This peptide was described several years ago because it showed a very large affinity for the neutrophil FPR1 receptor with a binding affinity of 2 nanomolar. And there was a study trying to use it for imaging. The problem is, as you can see, this is a rock. It's impossible to solubilize this in water. So the specific activity they managed to inject was very low, and the images were not that good. So we thought that considering, and this is the key part, considering the properties of our nanomaterials, they provide very good PET signal, but they are extremely hydrophilic. We would be able to bring this to the aqueous phase, so at keeping the affinity for the receptor, but with the good imaging properties that, because of the nano component, we could have. So we synthesize the nanoparticle the same way. We covalently attach the peptide on the surface, controlling the amount of peptide because we didn't want to make hydrophobic our nanoparticles. So we incorporate about 10 peptides per nanoparticle. We'll pass this quickly, different characterizations, the reproducibility of the synthesis. There is an extremely reproducible synthesis, checking that the gallium was inside. The size of the nanomaterials, the hydrodynamic size, before and after the attachment of the peptide, because it's very hydrophobic. You can see that there is an increase in the hydrodynamic size as is what was expected, and different characterizations to check that the peptide was there. In the end, what we got was nanoparticles stable in water, with a good amount of peptides and a very high specific activity. That was the initial aim. As a model, this looks weird. As a model, we wanted to use we wanted to target neutrophils. That is the purpose of this peptide. So we chose this model where after instillation of LPS in the animals, 24 hours after the instillation, you have a large accumulation of neutrophils in the lung. We check it. This is the total amount of the percentage of events detecting neutrophils in the lungs after the instillation. So we knew we had a lot of neutrophils in the lung. So then we injected nanoparticles without the peptide, nanoparticles with the peptide. We did PET-CT and of course histology and cytometry. So first results in the experimental conditions. So we have mice with neutrophils in the lung, and we injected our nanoparticle with the peptide. You can see here the typical distribution. This is the liver. This is the bladder, which is typical of these nanoparticles with the hydrodynamic size that they have. But you can clearly see the lungs here even better. There is a clear signal in the lungs that you don't have if you don't have the peptide. So we were very happy with this, but well, first of all, I always forget this. The biodistribution, you can see almost at 30% of the injected dose per gram was in the lungs in comparison to the control nanoparticles that were not present in the lungs. And if you isolate the neutrophils, 50% of the neutrophils in the lung had the tracer in the measurement, in the radioactive measurement of this neutrophil. So we were pretty sure that we were having a targeting of the lungs with these nanoparticles. But as you well know, macrophages tend to eat these neutrophils. Macrophages are also involved in this type of inflammatory response. So we were seeing here neutrophils and macrophages, only neutrophils, only macrophages. So what we did was to repeat the experiment, but changing this ratio. First, we did an experiment exactly the same as the first one, but previously we have depleted the neutrophils, injecting an antibody, which name I don't remember now. You destroy all the neutrophils for 24 hours. So in these conditions, you have macrophages, but you don't have neutrophils. And in this case, as you can see, we have the liver, the bladder, we have the heart, even the carotids. The nanoparticles circulate for longer, but you don't have a signal in the lungs. So no neutrophils, no signal in the lung. And then we did it the other way around. This is the biodistribution that I always forget. And then the macrophages. Now in this experiment, we depleted all the macrophages, but we have neutrophils, and we recover the signal. So when we have both macrophages and neutrophils, there is signal in the lungs. If there are no neutrophils, we have no signal in the lung. And if we don't have macrophages, we recover the signal in the lung. So we're pretty sure that we are targeting specifically neutrophils in the lung. But the key point is that we were able to do this because we were able to bring to the aqueous phase this peptide. And we could do that because of this large hydrophilic layer that the nanotracer has. Moving to another application that we are finishing now in Alzheimer's disease. This is in collaboration with Marta Cortés Cantelli. She was at CENIC. Now she's moving to the new Alcalá de Henares campus, the CSIC, the Cajal campus that has opened recently. So we are going to collaborate more than ever. In terms of Alzheimer's disease, I will tell you now which particular aspect of the disease we're interested on. But before that is the targeting aspect. So in the previous example, you have seen that we functionalize the surface of the nanoparticles and they target neutrophils. But when you want to use an antibody, sometimes that's not the best way, because even with the different methods that you have, as you know, you can have the antibody binding with the variable regions or in positions that reduce the availability of that antibody to do active targeting. So as you know, several years ago was developed this pre-target imaging that is based in bioorthogonal chemistry that basically splits the process into separate steps. So you have first the antibody that you label with a molecule that I will show you now. There is no signal, there is no nanoparticle, there is no radioactivity there. It's a small molecule, and you inject your antibody. You wait for the distribution because there is nothing radioactive, there is no nanoparticle. It can take from 2 hours to 5 days. You don't care because there is nothing there that would lose the signal. You wait until the nanoparticle has completely, until the antibody has completely focused, accumulated in the area of interest, and then you prepare your tracer. This can be nanoparticle or not. The first time this was published for cancer was a regular radiotracer, a small molecule radiotracer. And then you inject your tracer, it circulates, is excreted, and accumulates only where the reaction is happening. And this is the reaction. There are, as I'm sure you know, there are many bioorthogonal reactions that can be used, but this tetrasyne ligation is the best one because it's the fastest one. It works very well in water. It works very well with tiny concentrations of both components. So you only have to attach one of the components, the transcyclooctane, the TCO, that normally is attached to the antibody, and the tetrasyne to your imaging component, that in our case is the nanoparticle. And then it will react and accumulate where they were before. Two previous studies where we demonstrated this, the first one for atherosclerosis detection. Here we have different controls. This is mice with atherosclerosis, and we injected an antibody with this TCO and our nanotracer, the same one I've been talking, with gallium-68 and the tetrasyne. And I think you can appreciate here the typical half-moon shape because of the accumulation of the radioactivity in the aorta wall. Different controls, for example, the same experimental conditions, but with animals without atherosclerosis, there is no signal. Animals with atherosclerosis, antibody with the TCO, but the nanotracer without the tetrasyne, there cannot be bioorthogonal reaction, and there is no signal. And finally, a blocking conditions where you repeat exactly the same experiment than in the first case, but previously to that, you inject a large amount of the antibody without any modification. So it blocks the binding sites and you don't have signal. And if you put all the numbers together, you can see there is no uptake in the controls and a 15% accumulation in the atherosclerotic plaque. So we were very happy with these results. In fact, so happy that then we apply shortly after that to the fast detection of thrombi formation in the brain. Long story short, there were some animals with a mutation in the neutrophils that they were dying much faster than expected. Researchers, Andres Hidalgo, who was back then at CSIC, thought it could be a thrombus formation. So we applied the same approach to detect these thrombi. In this case, we didn't have time because after surgery, animals were dying so fast that we could not wait the 24 hours that we were waiting here between the injection of the antibody and the injection of the tracer. So we did it all together. We functionalized an antiplatelet antibody with the TCO and the nanotracer with the tetrasyne, mix them, co-inject them, and in 30 minutes perform imaging. So at the same time that the antibody is binding the platelets, our tracer is binding the antibody. We got these imaging results, very tiny because we are talking about the microarteries of the brain in a mouse. So imagine the amount of blood that you have there, tiny uptake that we thought was positive uptake, but we needed to check with histology, especially because of this. As you can see, this huge signal here are all the platelets in circulation that are giving signal, because we could not wait for this signal to wash out because the animals were dying. We had to do everything quite fast. So histology was most important than ever here. This is just some of the examples you can see here. This is a thrombus with hematoxylin eosin, and the same slice with pairs for iron oxide. So as you can see, the thrombus is completely coated with the iron oxide. Even for the tiny ones, you can see a thrombus here and completely decorated with the iron oxide. So we are pretty sure what was happening here. So this approach using a nanotracer and this bioorthogonal approach that we demonstrated here that was working is what we are doing with the two Martas, Marta Cortés Cantelli and Marta Casquero. This is a project of theirs that is based in the procoagulant state that Alzheimer's disease has, that at least 50% of the patients has a procoagulant state in the brain. Previously to all the things we know more about Alzheimer's, the accumulation of different plaques, previously to all that, at least 50% of the patient has a prothrombotic state. So to characterize that, we have been doing different experiments in PET and in MRI. The approach is the same antibody, in fact, antiplatelets, since platelets are the main component of this thrombi. We inject antibody, we wait 24 hours, and then we synthesize, inject the tracer, and 1 hour after that, we perform in vivo PET and MRI in different animals. This is just a summary of the results. This is a positive control that we use just to demonstrate again that this tracer was detecting thrombus. This is a carotid crash model where they create a thrombus in the carotid of the animal. Well, this is the experimental conditions and the control just to check what we already knew that the tracer detects these thrombi. If we apply this to Alzheimer's animals, I will leave this to the last one because I like it a lot. We did PET and MRI, starting from the bottom. This is PET results where we tested different groups, but focusing in the wild types and Alzheimer's disease animal. This is the percentage of injected dose per gram in the brain of mice. As you can see, there is a significant difference between the two groups. And as you can see also, the percentage of dose is extremely small because here we are pushing absolutely the limit of everything, because these are not animals with a thrombus like this one, that you have a large accumulation of platelets. These are animals without any thrombus, but with Alzheimer's. So the microthrombi they have is extremely small in an artery with a few microliters of blood. So even for PET, with the sensitivity it has, is a challenge. From an imaging point of view, it's difficult to see a hot spot like this one, but analyzing the images or after with a gamma counter after the experiment, you can measure that there is an excess of radioactivity, is an excess of nanoparticles in those animals with Alzheimer's compared to wild type. The same has been seen by MRI. And you will see this image and you will say, how can you get this image with these huge signals when you cannot see it in PET? Because this is a treatment of the signal. This is a voxel-wise analysis where you make a statistical analysis of the intensities in MRI for different regions. So it exaggerates, probably it's a false friend. It increases the difference between wild types and diseased animals. But what we can see is that statistically speaking, these are many animals. This is not just one animal. Statistically speaking, there is an increase in the intensity in the cortex, cerebellum, and hippocampus, that are three of the most important regions in Alzheimer's, if we compare Alzheimer's disease versus wild type. So these images are different, statistically weighted difference in intensity between Alzheimer's disease and wild type. And there is a clear tendency that correlates with this. And I say like this because if you put together all these difference, all this increase in the uptake, you see this blue line are wild types animals, and the yellow line are animals with Alzheimer's disease. And that there is an increase with age. We know that there is an increase in the Alzheimer's complications with age in these animals. And the older the animal, the higher the uptake of the tracer, something that doesn't happen with the wild types animal. Again, this is relevant in terms of Alzheimer's, this is relevant in terms of the application, but for the story I'm telling you here today, we can do this because we are using nanomaterials, because we are using nanoparticles that at the same time gives you signal in PET and in MRI, and that you can bioconjugate on the surface almost as you want. This is not easy, if possible at all, to do with gadolinium-based or fluorine-based PET tracer. This is not easy, if possible, at all. And the last part is the use of radiopharmaceuticals. That is probably the most important part in our lab right now. So radiopharmaceuticals are very related to theranostic experiments. As you know, in theranostic, you have a compound that ideally should be exactly the same, but you first use an isotope for imaging. You characterize the biodistribution, the uptake of the tracer in the tumor normally, and then you apply the same compound, but with a therapeutic isotope to treat the tumor. And then you can follow up how the treatment has gone. You may have several cycles of the treatment, but you can monitor how good the treatment has gone before and after the application of the therapy. The key part here is that apart from the radioisotope that has to change from an imaging isotope to a therapeutic isotope, the rest should be exactly the same. The same chelator, peptide, or whatever has to be exactly the same to be sure that you are therapeutically targeting what you have observed from the imaging results. So to do that, you have to design a radiopharmaceutical that basically is something like this: a targeting molecule, normally a peptide, can be also an antibody, a linker, and something to hold the radioisotope. Okay? To hold the radioisotope, because if you look to the periodic table, most of the radioisotopes, either with therapy, imaging, or mixed emission, are normally all of these. And as you can see, they are all metals, so you cannot covalently attach them. You need what it has done till now. You need a chelator to complex that radiometal, and then you can attach it to an antibody or to an organic molecule in general. So this makes the picture quite complicated. Every year you have tens of papers talking about chelators, different chelators for different radiometals, each one better than the other, but there is no perfect chelator. This is just a summary of many of the hundreds of chelators that are proposed every year. If every year you have this, it's because there is not a single one that works good for at least a wide range of radioisotopes. So following this review, that if you're interested is quite interested, what is an ideal chelator? What makes a chelator ideal for radiopharmaceuticals? Well, you must have a rapid and quantitative binding to very low concentrations of the radiometal, even in the presence of metal impurities, which is sometimes common when you have a radiometal. You have a small impurity of a coal ion, and because the concentration of the radioactive part is so low, even very small amounts of cold metals can compete with the complexing, and then you have a problem. They must have high stability in vivo, something that we will know happens with gadolinium. It also may happen with radio tracers. If it is an imaging isotope, you will have imaging results meaningless. If it's a therapeutic isotope, you can have problems of toxicity. The clinically approved compounds like Lutathera, for example, they are perfectly stable, but they are stable for that combination of that peptide with lutetium-177. What happens if you try to use it with another radioisotope? Then you can have a problem. You should have a straightforward bioconjugation with any type of vectors, and this shouldn't affect this stability that you should have. And ideally, you should meet all these conditions for a large number of radioisotopes. That allows you to carry out many different types of theranostic experiments, and you don't have to change all the chemistry if you want to move from a beta emitter to an alpha emitter, from a PET isotope to a SPET isotope, for example. So currently, there is no chelator that fulfills all these conditions. The situation is this: we have, for example, these 8 isotopes that are of interest for PET, SPET, and therapy, these ones. Each one has its particular chelator. Some cases, like radium-223, there is no chelator. There is one published, but there is not even a variety of chelators to choose from, so it's the worst case scenario. So from this variety of conditions, because each pair of chelator radioisotope has its particular protocol for binding, purification, etc. From this, we propose to go to this. So using the same platform I just showed you for gallium-68, trying to use it as a kind of universal chelator for all these 10 radioisotopes that span from PET to SPET, and for therapy, both with beta and alpha radiation. So this is what we did following our protocol, that is with the same that you saw for gallium, but expanding it for all the radiometals we were able to use. So you have here the radiolabeling yield results. As you can see, for most of them, they are higher than 80%, even for the smaller ones like copper and technetium, that is around 40%. You could do imaging with this, but in these cases, because of the chemistry of these radiometals, they are the only ones that doesn't work perfectly in terms of radiolabeling yield. In terms of hydrodynamic size, you can see that they are all the same. We have exactly the same platform with different radiometals in the core of the nanoparticle. This is the serum stability to check if the radioactivity is whole in the nanoparticle and doesn't go to the serum. This is for the short half-time radioisotopes. This is for the long half-time radioisotopes. You can see that the stability is quite good, even for the longer periods of time, and very interestingly, even for the ones with modest radiolabeling yield, like technetium, the stability is good, and the hydrodynamic side is the same. So the problem is not the formation of the nanoparticle, is the availability of, in this case, technetium to join the core of the nanoparticle. Well, some electron microscopy. This is the core size. Again, we have the same core size regardless of the radiometal we are incorporating. And then we decided to challenge our protocol, trying to fulfill these conditions I mentioned before. For example, here, this is the radiolabeling yield for 5 selected radiometals with smaller and smaller quantities of the radiometal to see if reducing a lot the amount of radiometal that was going to be incorporated in the nanoparticle, we had a reduction in the radiolabeling yield. And as you can see, this is not the case. We have reproducible and exactly the same results, even when the things doesn't work as perfect as for these 4. Even for technetium, we have consistent results changing the initial amount of the radiometal. And this is another challenge. This is initial conditions, but with very large amount of zinc, of cold zinc, like if we have a very strong contamination in our reaction. So this is a comparison of the radiolabeling yield with no contamination at all, and with 500 micromolar concentration of zinc, that compared to the concentration of the radiometal is a huge amount. Even with that competition, the radiolabeling yield is not affected. So at least 2 of these points we have fulfilled with this approach. We had all these nanomaterials. We checked these challenges I just showed you, and we wanted to demonstrate what could be done with this approach. So we carry out 5 proofs of concept. Inside of each one of these experiments I'm going to show you, there are many more things that has to be done, but it was just to highlight what it can be done. For example, multimodal imaging, something that is impossible to do with traditional chelators, but in this case, with the nanomaterial, we were able to incorporate in the core not just one radioisotope, but pairs of radioisotopes. For example, gallium-67 and lutetium-177. Gallium-67 is an SPET isotope, also a therapeutic one, because it emits Auger electrons that are of interest because they have a very short range for therapeutic approach. And lutetium-177, which is a beta emitter, which is the most used right now therapeutic isotope. The second one is the same, but instead of gallium-67, gallium-68. So we have PET and treatment in one tracer. And the last one, that is almost just for fun, to show that we can do it, because it's a mixture of gallium-68 and gallium-67. So this would be a tracer that gives signal in MRI, in PET and SPET, and the therapeutic gallium-67. Probably the clinical application of this is none. This is just a proof of concept to show that we can do it. We can incorporate almost any combination of radiometals you can think of. In terms of radiolabeling yield, they are very good. The stability is the same. They are in the core of the nanoparticle until they have decay, and you can carry out multimodal imaging experiments. We have seen in a healthy mice with no functionalization, so they just circulate, and in this case, they are taking in the liver. So CT, PET, because the gallium-68, and SPET because of the lutetium. Lutetium, apart from the therapeutic radiation, has some gammas that can be detected in SPET. So this is a correlation between the gallium-68 and the SPEC. Well, you can fuse the three images in one to see the correlation. So this was just to show you that we can do this. We can incorporate any radiometal you are interested on, and key for that with a very good stability in serum. Then we are also interested in glioblastoma. We are interested in active targeting glioblastoma, but before that, we wanted to check, is the EPR working here? You all know the EPR, sometimes it works, sometimes it doesn't, but we wanted to check what would happen with these nanoparticles, in this case, the gallium-68 one, if we intravenously injected in a glioblastoma model. This is in collaboration with Pilar López de la Rubia in Sols Monreal in Madrid. They developed this glioblastoma model in the brain of mouse. We injected the tracer, and I think it was 90 minutes after the injection. This is the brain of the mouse. You can clearly see an uptake by PET and MRI, because this is a PET-MR machine, and because our nanoparticles provide also signal in PET. I think you can see a more clear, a more bright, a less dark gray signal here because of the accumulation of nanoparticles and the fusion of both images. So they are accumulated, they are passively accumulated. In fact, we were able to calculate that more or less this tumor size has to be around 20 cubic millimeters to break the BBB, because they are crossing, because the BBB is affected, otherwise they wouldn't cross. And this is just a dynamic study, altogether the evolution of the nanoparticles with time, of course, the liver circulating, and finally ending up in the brain. So basically, they accumulate in glioblastoma. What would be the results with active targeting? For how long are the nanoparticles here? Is this therapeutically effective? Next year, you invite me, and I will tell you. Next proof of concept is targeting thrombosis, something that we had already demonstrated, as I showed you before, but in this carotid crash model, again, just to show the possibilities of this platform, that with the same platform that we just incorporated to radioisotopes, that we use EPR for passive accumulation, we can do active targeting with a pre-targeting approach. The same I explained you before. This is nothing new here. The same model, the carotid crash injury, and the same expected results. This is the animal with the injury, control animal, and as you can see, there is only a clear uptake where you have the combination of antibody and nanotracer. The fourth, I think, proof of concept, it was intratumoral injection in glioblastoma to check the activity of the beta radiation from the lutetium. This is something that it was supposed to work because it's intratumoral administration, but we needed to check it. So we prepared these nanoparticles, we inject it in the tumor. This is the biodistribution. No surprises here because it's an intratumoral injection. And these are the results. The summary of the weight of all the tumors and individual tumors. As you can see, control mice, the tumor grows and grows. In the case of the administration of the lutetium, as expected, there is no growth in the tumor. This is statistically significant here. Again, this is the starting of another story. The same that the EPR opens to study the active targeting, this opens the study of active therapeutic targeting. Once we functionalize this and administer it intravenously, we'll have something like this, probably not that beautiful, but let's see how far it goes. And the final one, that is one of my favorite, is the study of the hepatic versus renal excretion. As you have seen in all the results, we have uptake in the liver. For imaging purposes, that is normally not a problem. Even if you have a radioactive isotope, that is not a problem, because from imaging purposes, the dose, the energy that deposits in the healthy tissue is not harmful. So there is no problem in terms of imaging. But what happens in terms of therapy? Not only because the energy that the therapeutic isotopes provides is much higher, that only is enough, but also because normally in a therapeutic approach, you need 2, 3, 4, 5 injections of the nanotracer. So there is also an accumulation of liver, of iron in the liver that can be harmful. So we strongly believe that to make this therapeutic approach, we have to go for the renal excretion of the nanomaterials. Again, this is something that is not easy to do with a traditional approach, to change this biodistribution from hepatic to renal. Just changing the size, as we have done here, you can do it because you have the nano component that you don't have in the chelator approach. So Aitor, in his thesis, did a lot of experiments that are not here with cold chemistry, playing with the time, the temperature, the coating of the nanoparticles, trying to reach this threshold that we put here, about 4 or 5 nanometers, to reach the renal excretion. As you can see, these are experiments with already gallium-68. There are many more without gallium-68. These were selected from the cold chemistry experiment. And as you can see, many of them are already below this threshold. We consider that the nanoparticle is below the threshold, the composition, zeta potential, the radiolabeling yield, so trying to maximize the radiolabeling yield, the serum stability, and how far below this threshold they were. All things considered, this that we call 65-30, that is just the temperature and the time, were selected because, as you can see, they are below the threshold. They are above the 30%, the 25% radiolabeling yield, and they are very large in terms of radiolabeling stability. So we consider they were the best. This is just a comparison of these 65-30 samples with the regular ones with a hepatic excretion. And then we carry out the in vivo experiment. So this is the normal tracer that I've been showing you for the whole presentation. This is the normal hydrodynamic size distribution. This is the renal threshold. So if you inject this is a PET imaging, you get this. You have the liver, you have a little bit of a spleen, which is the typical aspect of this. If now you use the other ones, you have this profile. They are just below the threshold. You can almost see the liver, just a tiny shadow there, and a lot of all the dose in the bladder. So again, this is a positive result that open many things, because the longer the nanoparticles circulate, the higher that tape in the tumor. That would benefit this. But the dose in the liver is something we don't want, so that would benefit this. So now we have to study how is that taking the glioblastoma, passive and active glioblastoma. Is this extremely short circulating time enough for taking the tumor? Is enough for imaging? Probably it is. Is enough for therapy? Again, you have to invite me next year to see the results. And that's all. Many things. So just a general conclusion. I hope you agree with me, and the combination of nanomaterials and radioisotopes brings together the best of both fields. And this has implication both for diagnosis, therapy, or for the combination of diagnosis and therapy. And now I realize I forgot to put an acknowledgement slide. Juan, Aitor, all the people in the lab, and all of you for your attention.
Thank you very much, Fernando. A lot of applications with the particles, as you can see.
Te presto el mío.
Yeah. A bit old-fashioned. Yeah. There is room for questions, so if anyone want to ask something, now is the time. No questions?
Thanks for the presentation. I love the fact that yeah, from one particle you are able to target so many different diseases, and I think that's nice. And actually, the what imaging is also very nice. Regarding to this, I don't know, in terms of clinical translation, is this type of dual imaging or having several images in one particle, is this well seen by clinicians, or is this a problem? I don't know.
Yeah, I mean, to do that, in fact, I did something I have not done before, and I'm very happy to do it. I went to talk to several oncologists at Hoover, at Porta de Hierro, and now we are collaborating with them to ask them, we are thinking of this, and we have this result. This makes sense to you, or this is very nice for a paper, but and they are the oncologists and radiation oncologists. They are extremely excited with this theranostic approach. That's why Luta Tate has changed completely the field, because the possibility of having exactly the same chemical compound to have imaging with exactly the same chemical compound perform the therapy, and then you can follow up how this has gone. They really want something like that. And this makes that possible. That's something that you cannot do easily, as I mentioned before. With the chelator approach, you cannot pick whatever radiometal you want and do exactly the same chemistry and the same targeting. You simply cannot, because of the chemistry. This allows for that. Of course, there are many things ahead that needs to any barriers we have to cross. One is the traditional for the use of metallic nanoparticles. That is something that is there. But that's why I was telling that the renal experiments are key for me, because that changed completely the picture, because people is used to iron oxide, okay, big things, negative contrast, that they go to the liver. And for many applications, this is good. But for this is not good. For this, you need something that is swiftly eliminated from the body, but that combines imaging and therapy.
But I mean more in terms of, I don't know, if you have a radioactive nanoparticle and you can also do MRI, would a clinician on MRI use a particle that is radioactive at the same time? Or?
We are using less and less MRI. In fact, these nanoparticles, the renal ones, they are not active in MRI. They are so small, they has almost lost any magnetization. So for this application, the MRI is out of the picture. It's nuclear imaging and therapy, but no MRI. If you are interested in MRI, you have to, at least with this you have to increase the size, and then you have the particle elimination, and then you cannot use radiometals for therapy. So you have to choose what you want to see. But for this type of theranostic approach, it's nuclear medicine. MRI is not used really.
And if I may ask another question, and this is lack of expertise in imaging. So you have, when you have the PET and SPECT simultaneously,
yeah.
Why the PET look like there is imaging more, over the animal, and SPECT is very localized? I don't know.
Two things. First of all, the amount of gamma rays lutetium is emitting is much lower. In fact, it's not an SPECT isotope, it's a therapeutic isotope. So the quality of the image is not that good. But more importantly, the SPECT experiment was done much later than the PET experiment. So in the PET, you still see some circulation, but when you perform the experiment, then you move the animal to the SPECT chamber, all the nanoparticles had already accumulated in the liver.
Okay, thank you.
I have one regarding the renal excretion. I think it's pretty interesting to see that change in the pharmacokinetics of the particles, but it might be also a problem when, as you said, no, in the presentation, now you're gonna see this to image or treat a tumor, and you do either that by passive targeting by EPR or active targeting, functionalizing the particle with whatever, but you have a very short range of size in which you can play with. So for the EPR, it's going to be very difficult because your circulation in blood has been reduced a lot. And for the active targeting, you have the problem that as soon as you put something onto the surface of the particle, you are going to cross that range and going back to the hepatic elimination. So I don't know how do you see it, but for me, it seems to be quite challenging.
Yeah, it's true. I mean, one of the things I like about this, I hope, future paper is that it opens many doors for more experiments in the different 5 proof of concepts, because there are many things yet to answer. To that particular question, 2 things. EPR, we are not really interested. I mean, we did that to see if it was working or not, but we are, as you well know, we are very happy with active targeting. And again, for that particular point you are mentioning, I think, again, the answer is per-target imaging. We know they adding tetrasign to the surface of the nanoparticle. Practically, it doesn't change the hydrodynamic size, so they will most likely still be renal excretion. And we use the antibody. It doesn't matter how long it takes. In that case, I think we can play with short circulating times and high uptake. That doesn't mean that we have to play with these columns I show you, trying to increase a little bit the size, playing. At the end, we'll have to do a study of the dose that the animal received, and maybe we have to increase the hepatic accumulation so long it's not harmful, but to increase the circulating time, because you are right. Maybe, I mean, it's good that it's that short, but maybe it's too short for some things. So yeah.
Thanks. Actually, I have many questions, but I'll have a couple. In your first part of the presentation, when you were targeting neutrophils, I wasn't sure if I understood. Once it was clear you target the neutrophils, but was it a therapy involved in that?
No, that was diagnosis. That was just to check that we were able to target neutrophils and to diagnose inflammation, or in fact, that tracer was initially thought.
But how you diagnose inflammation? By the number of neutrophils? So if it increases respect to before LPS?
In fact, I mean, the thing is, wanted to develop a tracer that actively targeted neutrophils, thinking in studying the role of neutrophils in atherosclerosis. Then many things happened, and we didn't reach that atherosclerosis part. But this was, in fact, the first part of a project thinking in studying the role of neutrophils in atherosclerosis. So first of all, we needed to demonstrate that we had a tracer that specifically binds to neutrophils. And we choose that LPS model because it's the most used. And you know, there are a lot of neutrophils, and it was in the lungs, but it was also too easy to identify if there was an on-off signal.
And it was intravenous administration. Yep. And in the lungs, it distributed in all globules of the lungs, probably. Yes.
I think we didn't go that far. We did a bronchoalveolar lavage to take out the neutrophils, but to study, in fact, with the spatial resolution of PET, we didn't pay attention to that. In the image, they look more or less homogeneously distributed, but we didn't study.
And then in the other pathology, the Alzheimer's disease, you say that is active targeting, and it arrived to the brain, also by intravenous administration. So do you have an idea of the fraction that arrived there from the one that you injected?
More or less, we have an estimation with this percentage of the injected dose per gram that is quite low. I think it was 0.2, if I'm not wrong. Yeah, more or less, no less. Here, 0.1, 0.15 of the injected dose per gram of tissue. But because of what I was saying you, I mean, here in this type of experiments, for example, you have a much larger percentage of injected dose, but because here you have a real, let's say, big thrombus. Here you don't have a thrombus. I mean,
but the thrombus is inside the brain or is in the carotid arriving to the brain?
No, here, this is the positive control to demonstrate that the tracer works. This is a thrombus in the carotid, and it's a real thrombus. There is a blockage of the circulation there. Here, in the Alzheimer's disease, there is no blockage. blood is circulating
Yeah,
because they are microthrombi. So the number of platelets that you have there, I don't know the number, but are extremely small. That's why we have this extremely low percentage of injected dose, because as I was saying, we are in the limit of detection of everything we are doing, because there is no blockage, there is no real thrombus. There is just a procoagulant state. That is what they are seeing in with other
but
techniques.
for me, it's even strange that something arrives there.
Yeah.
So that is already a big success.
Yeah.
Okay, thank you so much. I have mainly two questions. The first one, it's about the premix that you show a first example where you were injecting together the antibody and the radioisotope, because otherwise they were dying, right, the mice? Yeah, my question is, do you think that there's a difference in biodistribution when you inject this premix versus when you inject it separately, since here you're modifying like the properties of the tracer?
That's a very good question.
I don't know if you compare it.
Yeah, I think probably yes, but I don't have an experiment to really answer you, because, for example, in this previous experiment where we wait 24 hours between antibody and nanoparticle, that antibody also goes to the liver. So I cannot tell you if these nanoparticles, if there is no functionalization, they go to the liver and the spleen. So here, because the antibody is already in the liver, and here, because the nanoparticle is binding the antibody in the bloodstream, we cannot observe really if there is a difference. I mean, to do that, we would need to do an experiment here, where instead of 24 hours, we co-inject them. And that's something we have not done. I think probably the final distribution of the nanoparticles, of these nanoparticles, because they are eliminated through the liver, probably wouldn't change, but don't have the experiment to really answer that.
Okay, thank you. And just out of curiosity, a second question regarding the animal, the uptake, it was different, right, in the Alzheimer's model?
In the Alzheimer.
It was in the Alzheimer's, yeah, in here, the brain uptake, right? That it's very different with the wild type versus the
Alzheimer.
Yeah, the Alzheimer one. Have you seen different uptake behavior between male and female, for example, or other like groups, especially for the excretion one? I don't know if maybe females do the excretion faster, or like, yeah, just out of curiosity, this kind of comparison.
Not in terms of excretion, that as far as I know, but in terms of uptake, here is summarized by age. But if you divide by sex, I think there was a small difference towards more accumulation in males, but I think, if I remember correctly, it was not statistically significant. There is a tendency, but it is not significant.
Okay. Yeah, thank you very much. I think it's good time to wrap it up. Let's give Fernando another round of applause.